Happy New Year. Sunny Lou Williams here to facilitate the 5th of 8 webinars for our state fiscal year 2020 to 2021 Cultural Competency Series. In keeping with the start of the new year, we are doing a look back on the last 2 years of webinars and looking at a comprehensive toolkit to be supporting a top 10 countdown for individual actions towards greater cultural competency for 2021. Before we get started, a couple of reminders on the why and the how of doing this project. First off, the Cultural Linguistic Competency and Health Disparities Committee, we have a vision of persons of all cultures and ethnicities partnering with local and state systems to achieve equity in access, services, interventions, and outcomes in our systems, with a mission to facilitate cultural and linguistic competency strategies throughout Indiana state and local systems to improve outcomes for populations vulnerable to disparities and disproportionality. In keeping with that, the how is through the mechanics of a cultural linguistic competency project, where the Cultural Competency Enhancement Project since 1996 has been to provide training services and technical assistance for community mental health centers and addictions providers throughout Indiana. Training services are designed to improve organizational effectiveness and efficiency in providing culturally competent services. We are able to meet that how by providing 8 technical assistance webinars, 4 regional workshops, and 1 annual conference each year. Today, we're going to take a look back on the last 12 webinars that have been completed and boiling that down to cultural competency top 10 actions for the individual in 2021. More simply stated, we're taking the best recommendations from the last 12 webinars to provide you a checklist of items that you can do individually to increase your cultural competency. Let's get started. Number 10. Taking action in response to microaggressions. Dr. Dennis Rudnick provided for us in the first webinar toward cultural humility on really looking at what are microaggressions, how are they subtly impacting negative connotations, stereotypes, and behaviors, and what can we do when we identify microaggressions. The action steps then as an acronym, where A is asking clarifying questions to assist with understanding intentions. Did the aggressor intend to actually commit a microaggression, or was there simply a lack of understanding or an opportunity for education? The C stands for come with a perspective of curiosity and not judgment. So as we see or identify or observe microaggressions taking place, understanding first to see if there is an opportunity for education, and then ultimately coming through with opportunities to bring further awareness and to correct and educate. The T, tell what you observed as problematic in a factual manner, being able to very specifically define what about the microaggression, if you are the one that is observing the microaggression occurring, of what is uncomfortable, what is offensive, and what is a way to correct language usage or the approach. I, impact exploration, really looking at how that particular statement, that particular comment had intended and unintended effects, and educating and again bringing awareness. O, owning your own thoughts and feelings around that impact and ensuring that as you identified those to be able to name those and share those. And then finally, next steps, requesting appropriate action to be taken. That simply could be, again, sharing education and awareness, or it could be a much more escalated situation where you account for utilizing the policies and procedures of your organization to report that microaggression. Taking action in response to microaggressions addresses microaggressions as they are occurring. And so action in each of these steps accounts for individuals to be hopefully further educated and brought more awareness before any escalations occur. Number 9, understanding Healthy People 2030 framework. This application of the Healthy People 2030 framework came to us last year through the support of Ayanna Johnson at the Office of Disease Prevention and Health Promotion. The Healthy People framework is updated every 10 years to essentially account for national metrics and overall health equity goals. The recent 2030 framework was just published in early 2020, and we look at a new organizing framework with updated vision, mission, overarching goals, updated data and streamlined objectives with the reduced number of measurable objectives, and also a much clearer focus on a set of national actionable priorities. Excellent objective categories that focus on core developmental and research objectives that really address public health issues and are showing how high impact priorities are progressing through current national data. And then of course, improved objective organization and website structure to account for better support for resources, training, and progress reporting through the Healthy People 2030 website. And partnerships and communications to support a comprehensive overview in case studies, alliances, and additional marketing materials to help with implementing framework objectives and models within your local community. Understanding Healthy People 2030 framework allows us to really understand the broader national objectives and how we in our communities can align those objectives on a national scale. In addition to understanding Healthy People 2030 framework, we have to, in our number 8, be able to leverage Healthy People 2030 as both a progress dashboard in the areas of leading health indicators and objective targets, really understanding the measurements behind how we approach metrics and also measurements within public health. And then also as a resource, great listing of evidence-based practices, policy levers with policy language and adapting new focuses, new areas of funding, and of course, accounting for constituent wellness across. We also look at state coordinators as a resource and having that as key individuals across each state rolling up progress objectives and reporting on a national level. And looking at finally leveraging Healthy People 2030 as a program implementation guide in support of program planning, and then also tying it into the state health assessment and improvement plan. So number 8, leveraging Healthy People 2030 as a fantastic progress dashboard to see how we have been moving the needle, as a resource to access great information, and as a program implementation guide to help us with the technical assistance aspect of the great work that we're doing in the space. Number 7. Number 7 is an opportunity for us as individuals to take the implicit association test. The implicit association test was designed by Harvard University during the formation of Project Implicit, and it counts for a measurement of strength of associations between concepts. It showcases implicit bias and actually measures implicit bias and accounts for time taken to make selection as a key factor. Individuals that take the implicit association test will then be provided a report to showcase automatic preferences based upon racial, ethnic. This is important to understand in looking at associations with quick word and also preference associations to identify where there is an understanding of implicit association, and also where there is an understanding of additional demonstration tasks that can apply the same through social groups, personality, gender orientation, and other classifications of implicit bias. Taking this implicit association test helps us to have an initial measurement of our preferences and our known implicit biases and unknown implicit biases, and accounts for opportunities for us to really rewire, retrain, and re-identify and self-identify where our biases lie. Number 6, Using first-person language. Using first-person language is incredibly important in being able to have supportive language in addressing our patients, our communities, and the groups that we serve. So a couple of recommendations here. Don't refer to individuals by using a group label. Instead, honor the individual by using their name. If you're unsure or uncomfortable in using demographic descriptors, work with your organization to identify culturally competent and appropriate scripting and practice the vocabulary. Support an understanding of patient identity questions and conversation starters to help ease the discomfort or the lack of certainty. Ensure that those are then addressed to patients and also asked for their preference and their choice of language as well. Some common examples of inappropriate usage: the mentally ill, the homeless, referring to individuals by their sexual orientation and or gender identity, calling individuals addicts, or using plural forms of racial ethnic descriptors. Instead of doing so, recommendations. So if you're using a general descriptor, instead of putting a "the" in front of the general descriptor, identify instead that you're speaking about someone who is mentally ill. When you want to speak about very specific cases, instead of broad-based or overgeneralizing and using terms such as the homeless, instead be specific and name the actual specificity that you're discussing. So Jack is homeless and thus needs support with housing assistance. Referring to individuals by their sexual orientation and or gender identity, simply use the individual's name, not the label. And when we refer to diagnoses such as addict, instead say person with substance use disorder or person with, fill in the diagnosis or fill in the disease state. And then in any cases where we're using or tempted to use the plural form of the racial ethnic, instead say the person's name and also self-check if the statement that we're about to say in the plural form is actually perpetuating a stereotype before making that comment. It's easy to fall into overgeneralization, oversimplification. What we want to do is to be specific and also account for individualized descriptors instead of general. Number 5, we want to highly recommend that everybody review the 15 action steps of the national CLAS. So what is CLAS? Culturally and linguistically appropriate services that are a way to improve the quality of services provided to all individuals, which will ultimately help reduce health disparities and achieve health equity. The 15 principles start with the principle standard, which is providing effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. In this initial principle standard, we're essentially saying in order to deliver great healthcare, we have to be respectful, effective, efficient, and also consistently improving upon the service that we're delivering to our core constituents. The CLAS standards are then further broken up into governance and leadership and workforce. Give everyone a moment to read through 2, 3, and 4, and specifically accounting for a summary of those items to ensure that we have the policy and procedures in place to offer organizational governance and leadership that supports recruiting and promoting a culturally and linguistically diverse workforce that is responsive to the population, and educating and training that workforce in culturally linguistically appropriate policies and practices on an ongoing basis. The next standards also look at communication language assistance as deeper dives, offering languages to individuals who have limited English proficiency, informing all individuals of the availability of language assistance services, and ensuring the competence of individuals providing language assistance and providing easy to understand print and multimedia materials. The next standards account for engagement, continuous improvement, and accountability. establishing culturally and linguistically appropriate goals, policies, and management accountability, and infusing them throughout the organization's planning and operations, conducting ongoing assessments and continuous quality improvement activities, and collecting and maintaining accurate and reliable demographic data to monitor and evaluate the impact of CLAS on health equity and outcomes and to inform service delivery. Continuation of that same grouping, conducting regular assessments to ensure that the needs of the area are supported and that the appropriate cultural and linguistic diversity of populations in the service area are represented. Partnering with the community to design those policies and to ensure that those services are also culturally and linguistically appropriate. Creating processes that account for conflict and grievance resolution, and to ensure that we continuously learn from those. And then, of course, to communicate the organization's process. So as a toolkit and a framework and also a continuous improvement standard, the National CLAS is really the go-to framework when we consider cultural competency as an organizational standard. And on to the next. Number 4, knowing how to impact policy change. First off, we want to understand and make sure that everyone is well educated about the current status and current challenges, current needs and pain points of the particular policy or lack thereof policy that will support better health equity and overall providing better healthcare delivery services to our constituent. Educate, educate, educate. Once that's been well defined and the awareness and the education has been shared, then we need to also recognize what is the value of that change to our existing communities, to us as providers, and also to the patient individually in recognizing how that policy change is pushing further equity. We do have to be very clear about identifying real challenges and opportunities in identifying how those challenges will be resolved and also identifying what ongoing opportunities and impacts there may be. We want to join institutional forces and create unlikely allies and partnerships for advocacy efforts because you really need to have all perspectives to account for how will the change be impacted and overall how we will continue to provide continuous improvement. So many voices in that help to support an understanding of greater overall and total impact. Using your trade associations for governmental relations, telling your story with real data and real people to really have a face, a statistic, a measurement, and also an overall improvement focus for how and who this impacts. Launching industry-based local research agendas, understanding how to capture the data, how to continue improvements on data collection, and how to see trends in changes in that data impact the overall community. Talking to elected officials, both publicly and privately, to account for, again, the education and support and understanding the position of where our elected officials are on that particular policy change. Investing in community outreach to diverse populations. Looking at, from a diverse population perspective, getting the feedback, the key informant interviews, the perspectives from diverse populations to understand the intended and unintended impacts of policy changes. And of course, investing in longer-term, innovative, creative, and connected solutions so that a policy change is not one and done, but that the measured impact on it is reviewed ongoing with continuous policy change towards further equity and further improvement. Number 4 lends to really an opportunity tactically on a key area that we've discussed in multiple webinars and still a continuous trend of solutions that we want to approach, and that is identifying limited English proficiency need in our service areas. As we continue to have in-migration changes and community makeup changes within our counties and in our state, we have to use available data to understand what languages and what language needs are being spoken and what limited English support is needed within our counties. So a couple of good resources here, both on a national scale from the Limited English Proficiency website, and then also down to a language data by county supported by the Indiana Department of Transportation in understanding what is the needs within our counties and what are the languages that need to be provided in support of better individual understanding and management and ownership of their healthcare. One specific area as a toolkit that was broadly asked for in prior webinars in Limited English Proficiency was specifically how to have an initial conversation with new patients and new community members of their chosen or preferred language to receive healthcare. So simply do that by displaying I speak cards in the front office that help with language identification. There are several different translations and graphics of this card that can be downloaded from the Limited English Proficiency site with the link to the direct I speak card product access there. Free, downloadable, and printable. Number 2, identifying and attending additional training and cultural exposure opportunities. And this is really powerful and impactful because as an individual with this as a top 10 action, you're looking really at continuing opportunities to further be curious, be connected, and be well researched. And that impacts locally by being able to attend training opportunities directly and learning about cultural exposure opportunities to participate in. We have to be intentional in being part of the communities that we serve. And so with that, the continuous search, the continuous driver to be curious, be connected, lends us to being able to look at not only cultural competency as a continuous source of strive and motivation, but also the opportunity in participating in equity and identify where policies, procedures need to be further improved to ensure support of equity. And coming down to identifying key informants to be a voice of perspective, is important to have multiple key informants for each of the different areas of cultural competency that we're exploring. And remembering that no one person can be the voice for a group of people, but rather that the contributing voices across allow for a better understanding of connectedness to that particular racial, ethnic, gender identity, and or community-based constituent. And our number 1 top 10 action for individuals for 2021 to maximize cultural competency is to maximize equity literacy through trusted resources delivered to your inbox. If you haven't already, please subscribe to the following links here with organizations providing weekly, monthly, and quarterly resources in support of cultural competency, issues and solutions on minority health, equity literacy framework, and LGBTQIA+ health education and case studies that are coming through of new and innovative interactions and models of care. And of course, do access as well the equity literacy framework along with the DMHA website for where you can find the cultural linguistic competency project resources and all the webinars to date posted on the YouTube channel. As we look at 2021, we hope that the last 30 minutes of overview help to consolidate and compile your must-take action top 10 to support a comprehensive cultural competency learning year.